No tengo nada tampoco.
Seriously?
Because you have to be a part of it, and it depends on what email you're sending from. That's the other thing.
What do you mean?
You know, like if you're not part of the Google group or the Google groups, then you can't send into it sometimes.
If you're not part of the Google group.
Like if your email address is your Gmail or your Breast Health, and you're not part of the email group, then you can't send into it. This is an exclusive group.
You can just do a normal Google Hangout and invite people individually.
Yeah, that's gonna take a lot of time, but I did think about
It
it.
takes a lot faster than the last 10 minutes you've been doing that.
Well, y'all have some time to read your article, so I'll figure it out by the time y'all are done reading.
Two people already on the link that was given.
Which one?
The one on the didactics email.
Yeah, that one's not gonna work.
Whoa.
Okay, now it should be working.
That's weird.
What'd you do?
Sent it from my email address instead of the residency email
Yeah,
address.
just shut down.
Do you have
All right, can someone test the link?
Awesome. There we go.
Yeah,
I got it.
it's working.
Working? Ah, praise the Lord. All right, so those of you who are new to this, we usually just spend the first 10 minutes reading the article because the majority of the time people haven't totally read it yet. So
What?
take 10 minutes to do that, and then we will start discussing. And if you already did read it, awesome. You can start looking at the questions on the sheet of paper in front of you.
The setup of this experiment seems like it's from a movie. Like it seems like social experiments that are on this level of
Moving people Yeah.
and choosing who gets to move and where they get to move.
Sounds
and,
like Tenant Health would get sued over this. You know what I mean?
Aren't we supposed to have med students starting that? Aren't we supposed to have med students starting that?
Yeah, that should be. They're probably in morning clinic and still with residents that were in clinic this point. The first Monday afternoon that they normally do like that. So this should be here. Yeah.
Oh, great, that just complements the body odor and smell. Everything.
What, universe?
I'm just saying it complements. It
I kind of said body odor smell. I don't know how this.
from the
Those two
food.
together on his high.
Yeah, exactly, exactly.
Apparently your tacos smell like armpits.
What is that?
Apparently,
No, it's the
a little Tino, it's actually my armpit.
That's a whole lot. That's so much. Really?
You're at Germantown today?
Casting room in the morning. What'd you do?
Oh.
I was looking for Sherman.
So hopefully,
Soto.
Is it just you?
hopefully I can get changed to ER if we get in the new ER, which is what the schedule is supposed to be. So you don't ever have to do something you want to do. Because I'm scheduled for like multiple days of casting room, which is very little to no beneficial value. I mean, it's good for a little bit, but
Yeah, I think I only have 1 or 2 days. I think they probably did that because you were the backup patient for the second.
There's nothing.
I guess he didn't. That's
Alright, we have a fairly decent group now, so let's go ahead and sign questions. So Glenn, if you can take care of question number 1. Remind myself what the questions are. Dustin, if you can take question 2. Chelsea, if you can take 3. And then if Whitney and Chad want to take 4. Diego and Dakota take 5. Or wait a minute. That's a 1-person question. Diego, take 5. If Dakota and Ben want to take question 6, and then Miriam and I can do question 7.
results.
I read.
Yeah. We're about the same
Thank you
place.
for your honesty.
We're in the same place.
And we decided that we can't interact, right? Doing it this
There's
way.
more interns.
Oh yes. If you do the actual Google,
Goodbye.
and can't make it taste.
Okay, guys. Yeah. Wanna keep that over there.
Ride together. Interns for life.
No, I hope not being in there.
Is it okay to share with Dakota? I'm gonna get that share that one.
I would love to.
Thank you so much. For those of you that just walked in, we're just taking a couple of minutes to read through the article, in case you haven't, or to read through it a little bit more if you only glanced at
Excuse you,
at
sir.
it.
You got it.
What do you want those guys to do? I don't think they're-
Sorry, I see you.
Living the dream. Tabitha holding down the fort. Tabitha holding. I didn't play this morning. You guys are there by yourselves. Nice. Welcome to the first day. That's rough.
That is rough.
Who's the attending?
Right.
Okay.
Oh.
That's the best one that you could have had on your first that day alone.
Oh, really?
I really
They're all good. They're all have different pros and cons.
You let me go at 9:30 the day before my vacation started.
I'm trying to find
Do you just round it and
Because it was the day before I found out I was going to Arizona, and so I was not. My head was not working
Hey, you
anyway.
guys, these guys.
I don't know. So if Lucas and Eric, if y'all just want to be thinking about question number 7, if you had a chance to read the article, good quality study, is it relevant, and would it change your practice of medicine or what you do? Everybody else has like assigned questions, but
Have you seen?
Do I have an assigned
thinking
question?
about
I've seen
5 with
it.
me.
Think about 17.
We can do 5.
Do what?
There's a very low
Didn't I already
percentage
give you a
actually
partner?
use their voucher.
No.
Yeah, it's kind of weird. Like half.
Like only half of them.
Well, if you think you need help, you're welcome to recruit Lucas or Eric to your team.
Does
Whoa.
the change is the change based on those actually moves or based on the whole they tend to treat?
Yeah, they did make. It's kind of weird, almost like the commissioner. Like read it out.
Yeah, so they're similar, but they are actually different.
Yeah.
We'll go over it. It's the way that the questions are asked.
The article.
Why they were
So the question that you come up with, Dustin, should be very specific. And your question has more to do with like what it talks about in the intro. And
I got you. I'm trying to sell you.
Let's try and get one.
Who has the admission pager right now? Do we know?
the admission page.
Yeah. Were you on?
The super doc pager?
Yeah.
I've got the super doc pager.
It's the admission pager. That you have to be carrying, right? Because once we have an admission team, you have it right now. We need someone to replace it on my phone so they can carry it.
That'd be lovely. I'd really appreciate it.
Someone here is gonna get signed up for it. That's a matter of lives.
Busy. Who's on super dog?
Did my. That's all.
Is there an upper level on PPD?
Yeah.
David Michael. And then Dakota's doing an outpatient ER combo.
Oh,
So
yeah, that's harder. I was gonna say, I was just on ED and it worked fine because I was up late most nights anyway. Yeah,
community
but
health, Alex Long is there, so he could do the second.
Just take a week.
Yeah, just with the weeks. In this interim when super doc is doing much more than they normally do. As far as like having to have a pager on all the time. You do the first week and then
you don't get very many calls. I got like 4 to 5 calls per week.
so every other. now that they're getting it figured out and you're not getting hospital calls on accident and you're not getting random stuff.
I didn't get any hospital calls.
When I carried it over 4th of July weekend, I got it all night long. Yeah, it's all snare calls. But now, and then OB. So make sure you
one
read
time, or are we
Andrew's emails
ready
on the
to
OB
discuss?
to the doctor responsibility.
I'll take like 3 minutes more.
You work scheduled for next month, the first week, just your first choice. Send email to you now.
I'll schedule for it.
You're the first 2 weeks of December. Now you're
Okay, everyone reasonably ready? No, just little murmurs in the background. All right, we'll go ahead and get started. So question number 1, why was the study created?
So in kind of in summary of the introduction, few chapters, maybe paragraphs, they kind of cite that there have been a lot of studies, several studies on how poverty and racial segregation and other factors are associated with obesity and diabetes in certain populations. And they even kind of cited in reaction to that, even the Surgeon General has kind of come out and said we need to try to make certain healthcare, nutrition and physical activity and all more accessible to certain communities, certain citizens. I mean, all citizens. He cites, and they've even done specific pathways explored on like how adding grocery stores or exercise gyms or even healthcare providers or like safety in certain communities, how those influence certain nutritional or in these some of these factors. But I guess one of the things that it's kind of unclear at this point and why they created this study is the idea that neighborhoods themselves haven't been directly isolated and seen how they directly contribute to obesity and diabetes. So kind of trying to isolate neighborhoods themselves, not like any changes in neighborhoods or certain factors about neighborhoods, but the actual just generally neighborhoods themselves and how they factor into obesity and diabetes.
And I would just add to that specifically poverty, right? That particular quality of a neighborhood, the percentage of the poverty level. Sounds good to me. Dustin, question number 2. The main question the study is asking.
Yeah, so like Glenn said, they use the moving to opportunity data to look at specifically how poverty relates to diabetes and obesity. So I said the main question is, do neighborhood environments contribute to the development of obesity and diabetes? And more specifically, is there an increased risk for diabetes and obesity for individuals who live in a poor neighborhood compared to those who live in a neighborhood that is not poor, as in greater than 40% above the poverty line? Yeah, and they asked this question using randomly assigned variations.
Just 10 to 15 year follow-up is what they looked at. So, nope, sounds good. So question number 3 is my least favorite question every time we do this. And this one is particularly weird, so I didn't even get it right the first time. So Chelsea, just share with us your thoughts and we'll refine them from there.
Well, I mean, I looked at the title and I see the word randomized, so automatically just go that direction. So I'm going to say it's a randomized controlled trial, but on the analysis, I don't even know if that's right, but on the analysis, I know like meta-analysis is 1, randomized controlled trials with definitive results is 2, randomized control with non-definitive results is 3, and then you go on to the cohort, case control, and all that. So I would think that it's, I mean, looking at the confidence intervals and all that, it seems part of it is non-definitive, right? So I would say that it's probably 3 out of this on the scale of 1 to 7 as far as, I don't know. That's what I get.
So yes, I agree with you, randomized control. Does anyone else have any thoughts to throw in the pot there? So strictly speaking, randomized control, yes. You could also potentially call it a cohort study, right? Because you've got a group of people that, you know, are, yes, cohort by definition, prospective cohort study. You got a group of people where you're adding a particular factor and you're following them long term to see how that particular factor affects. You have a cohort of people that you're following for a long period of time. But this is not it's not what we tend to think of in terms of a cohort study where we have like a medicine that we're giving or a particular treatment or anything. This is more of a social experiment, and so it's kind of a cohort study, but not in the sense that we usually talk about it. But as a randomized control trial in this public health like social experiment kind of arena, you could argue that doing it the way that they're doing it is probably almost like gold standard type level of evidence because of the fact that it is controlled and randomized and the cohort portion of that. So it's hard to say exactly since it's a social experiment and not a true cohort study, but it's probably in the hierarchy of doing experiments this way, fairly high up on the rankings. So, what exactly did anyone read like what exactly they randomized and what exactly the blinding was and the control?
So they randomized into 3 groups. One group was the voucher low poverty with an area of 10% poverty. They were given a voucher and then they used that to was just given a voucher, not accepted to just a traditional voucher. The area and the third one was the control group voucher. And the blinding was the reviewers who made it 10 to 15.
Yes. So we're getting a little bit into study design there, but yeah, so the randomization occurred just between like the demographics, essentially, gender, race, etc. And then, like she said, the blinding occurred when these interviewers, hey guys, welcome. The blinding occurred when the actual interviews were done. So based on what we know had to happen, like the interviewers themselves were not told which category each person went into, so what kind of voucher or no voucher that they were given at the very beginning of the experiment. But there's also a limit to how much you can blind someone because the interviews were taking place in these homes. And so they did have some idea of what kind of conditions that they were currently living in, which may or may not affect much of what the data, but just something to keep in mind. All right, moving right along. Question number 4, the study design.
So yeah, kind of what Sherry was talking about. They took about 4,500 people, and it looks like as long as there was a woman in the household was kind of.
Is that why those people dropped off?
I don't see. There's a part that says.
There's like all these people that dropped off. Did they say why?
It was like a phase 1 and phase 2 follow-up.
No,
No.
excluded before the phase.
449 were
In the
randomly
traditional
excluded.
group.
Did they say why?
No, they don't say
Okay.
why.
Okay.
Kind of like each level they are.
But no, that's the.
Sorry.
Yeah, I
I
don't
thought
know
that's what we
why.
were talking about.
Yes, at least 106 were families that were not headed by women.
But they don't talk about that in the actual article, which is.
No, it's just in the scheme.
It's just in the ski, and they interviewed the women of the household, and it said whether or not they were the head. So
Mhm.
some of it's a little confusing and not very clear, just kind of how it's written. But so yeah, randomly assigned into 3 groups, like Sherry said, and they took baseline surveys of BMIs and A1Cs, and then followed up in an average of 12.9 years, seemingly to repeat those same values and see. And it looks like they followed people even if they didn't use the voucher. They're still included in the data.
For the exclusion thing, I remember reading earlier they said they had budgetary reasons. I didn't follow up with a certain portion of people in that group. So that was part of it.
The dropouts he's talking about was before that,
Yeah, but.
like early on, not, or maybe I misunderstood.
But
Maybe
no,
it's a
that's
technique,
the
I
one.
don't know.
Yeah, I think it's that they were randomly selected for exclusion. Yeah, because they
So
just
they're
randomly decided.
Yeah,
not
it's like
to
at every
do
level
it
they
for
do that.
budgetary reasons, is what it said.
The intention to treat's a very common setup across every study. It's always very odd, but it's supposed to. I don't want to finish your meeting.
You started with Bob.
But it's supposed to,
Finish it.
it's supposed to
I'm
basically
quizzing
say
you.
if there is a difference, it really means there's a difference. Basically, if there's a difference that's found in intentional treat, because sometimes if you don't do intentional treat, then you're left with more concern for some kind of bias or more concern that the actual results that you're finding are not truly there, which would be.
It protects against crossover and dropout for specific. You end up with a population that followed the treatment through for a specific reason, and that's actually what's affecting your results, not with the factor that you're actually trying to study.
So it's more realistic.
Yeah, basically it tries to eliminate other causes for why there's a difference.
And realistic in this case too, which we were going to talk about a little bit later, but since you brought it up, since it is a social experiment and not a true, whatever you want to call it, prospective cohort study, the likelihood is that if you actually implemented this in a social setting, that 50% of people probably wouldn't use the voucher, and so that makes this data even more applicable to this patient population. Like if you're actually going to implement an intervention like this, they're still showing, well, we'll get to results, but anyhow, other things about the study design, we mentioned that it is an intention to treat. We mentioned that there are 3 different groups So obviously your variable group, below poverty voucher group, is the intervention group. And then what about these other two groups? They have a no assistance and they have a traditional voucher group. So what are we looking at there? Like one's a control, obviously.
The no intervention is the control.
And then I think it's just to see if giving a voucher in general helps versus giving a voucher that's for low poverty. With counseling and that kind of stuff. Like, you're just giving a voucher. So is that like a predicts against bias again?
I think we were looking at it in terms of almost being like a second type of control, to truly isolate if the moving to, because there's a lot of voucher programs out there for housing supplementation, but they really wanted to find out if the neighborhoods these people were moving to, if they were higher income areas, if that would affect health more than just the programs, most of the programs that are in place now that just give you a voucher and you can choose where you want to go.
The other thing that's interesting about the voucher group is they only live there, like they were only, after a year, they could relocate. So a lot of these people, even if they did relocate, that doesn't mean they stayed there for the 12.6 years where everyone followed up. And so I guess that goes along with the intention to treat and all the other things they're trying to control for is that they may have only lived there a year and then moved back. We don't really know.
What's interesting is the poverty rate. That's changed it despite.
Yeah, we'll get there.
Yeah.
But yes, and if you look at the table too, the average number of moves was like 2.7 and 2.9. So these people did relocate more than once during this period of time. Okay, question 5, primary and secondary outcomes.
So basically, I think that was me, but I thought I was 6. So obesity as basically defined of a BMI of 30, 35 or above, 30, 35, and 40, and then a glycolate or diabetes or uncontrolled diabetes of a hemoglobin A1C 6.5 or above.
And then secondary things that they looked at, they didn't include full analysis for all of these things, but I think there's some like supplemental stuff that you can look up online. But they did look at dose response, so the total time actually spent by each person in the low poverty areas. They also looked at census tract poverty rates, which is I think what Ben was kind of getting at, seeing actually what the poverty rates in poverty rates of the neighborhoods that these people are actually living in at 1, 5, and 10 years. And then they also in table 2 have reported some select questions about safety, health exposures as well. And then somehow question 5A got deleted off the sheet, but question 5A, or B, I guess, should be, are there any major differences in table 1? Because table 1 is kind of the randomization. So take a look at that for a minute and see if anyone sees anything that would call any of the data or randomization into question.
It looks like they're all pretty similar, but so like the low poverty voucher looks like maybe more of a white higher percentage, but they don't list like p-values. So
Read
we don't really know.
read below it. So
Does
they
it
ran
say
an
that?
omnibus F test, failed to reject the null hypothesis, and the baseline characteristics reported. They're the same across the group, and they give a p-value. Yeah. So they ran like a big, I don't know statistics, but
Yeah, it's not,
they
it looks
kind
like
of
it
put them all
wasn't a
together. It
1-to-1.
sounds like.
We did notice that there were slightly higher rates of being white, employed, and enrolled in school in the low poverty voucher group, but obviously they didn't find those statistically significant. So,
But is that, and this is out of the entire population that was randomized to that group, not the ones who actually use the voucher.
correct. Correct.
So it's not like so it was they didn't like self-select into the group that was
No.
going to be proactive.
They did not. Well,
Right.
correct, yes, yes,
This is before that.
because that would have been before that. Okay, so moving right along, let's talk about the actual results that were reported.
So the primary outcomes are listed in table 3. They compare the BMIs greater than 35, greater than 30, and greater than 40 at the 10 to 15 year follow-up, which I guess they kind of varied. It was like 12 something years overall. But you see the major differences in BMIs. So the middle there, the low poverty voucher, 31.1% prevalence compared to 35.5 on the control, and then 14.4 compared to 17.7 on control, 15.4 on the traditional. So as far as control and low poverty voucher, there was a significant difference between the BMI greater than 35 and greater than 40 between those two, and then between the hemoglobin A1C values, 20 compared to 16.3 in the low poverty. And comparing BMIs between traditional and low poverty, those were actually not significantly different, but the hemoglobin A1Cs were. So yeah, overall the control and the low poverty had the BMI difference and a hemoglobin A1C different, which was improved in the low poverty voucher group. And then compared to the traditional, the BMI was the same, but your hemoglobin A1C level was lower in the low poverty group. That was the primary results, primary outcome.
Sounds good.
Let me say that the hemoglobin wasn't technically significant between the low and the traditional voucher, but they were like it was approaching statistical significance. Or
They
something.
said it was trending toward,
Trending
but
toward.
it doesn't.
Trend towards a significant difference. I mean, you're comparing, I guess it depends on the number, but 20.6 to 16.3 compared to 20. I mean, if the control group was significant, why would the traditional voucher
That's weird.
be different?
And I like to think relative risk reduction makes more sense in my head than just looking at some of these numbers. So they reported it as 13%, 19%, and 21% for each of the three, the BMI over 35, BMI over 40, and then the hemoglobin of 6.5 between the no voucher and the low poverty voucher groups. So that's 13%, 19%. Which I don't know, I'm trying to decide if I'm thinking about this right, but if you only have 50% people or adherents actually using the voucher, you would be worried that you'd be less likely to see an effect if it was there, right? So I was kind of impressed that this actually turned out to be significant anyway, even with like the fact that only 50% of people were adherent, plus the fact that, as we mentioned before, the poverty level in the neighborhoods that they were living in kind of evened out by the end of 10 years. So there was still an impact that was seen. So was it a good quality study? Is it relevant?
That's us here in the corner. Do you guys have anything to add first?
I think overall, you could say it was better than it was worse. I mean, there was a significant correlation between diabetes and obesity and the neighborhoods you lived in. So, but there were also limitations in the study that were pretty significant.
It wasn't really randomized. It's volunteers.
True. So not randomized in the sense that you did have to volunteer for the program. I think it was like 1/3 of people that were, a quarter of people that were eligible actually applied to it. But it was randomized after the fact. So the people that did volunteer for the program were randomized into the 3 groups. So there could definitely be some selection bias at the front end, whether or not this is applicable to or would benefit the entire population would be questionable. You'd have to have people that are at least motivated to participate.
So yeah, I think based on just like all the results, then you can read like the strengths and weaknesses of the study at the end. I think so. The p-values were significant for the differences with, diabetes and BMI. So yeah, there was some significant differences, but there still was like these were a volunteer group of people. It was primarily women with children. It was excluding, some of the other populations as well as men. But I think overall we can say, yes, there is an effect of social neighborhoods to obesity and diabetes. But to make a hard and fast rule, like the specific statistics or the numbers, like I think that's a little difficult to study because it doesn't include all peoples. But I think, yeah, you can say.
It might make it worse. It might, Lisa might be better than expected because these are proactive people, and it's going to be worse when you're not, right? Because like supermarkets are not going to be in the area, and fruits and vegetables are going to be less of a priority. You're going to see less people running down the street or walking their dogs, and so therefore let the social effect, like I'm the only one in the street that's not walking my dog or whatever. So I think overall, like I was surprised too with the results, but just as a whole, just kind of population experiment type of thing. It's pretty interesting. Even being there for just a little bit that you were pointing out made an impact for the rest of the 12 whatever years that people were there. So.
And they did say that they found some significance in the dose dependence, that there was, more of an improvement when they actually teased out how many years in higher income areas per person they actually lived in, that there was a difference there too.
Did they take the groups after we took the vouchers and moved? Did they compare them to each other at all anywhere? Because I wonder if there's something inherent in the person who would actually take the voucher and move compared to the person that wouldn't. Like they all compared them at baseline, but then after the people that took the voucher, like was there something?
You mean who was adherent and who wasn't?
Yeah.
I don't
Not that I
know.
didn't see anything.
That
was
was an
it more
intentional
women
trade
or was it?
analysis.
It'd be interesting to see what the difference, if there's any statistical significance.
Or just
about
like who they
why
were.
or some other reason why they moved, and then you could.
There's so many like confounders. I feel like that really make any.
And even having the measurements, I guess, like 10 to 15 years after the fact. Like I'm even like, this isn't scientific. I'm just thinking like, say I lived in Mitchell Heights for like a year, 3 years, whatever it is. Like, then we look at how things are like 15 years from now. 3 years, guys, for the rest of my life, whatever. But 15 years from now, like I didn't see anywhere in here about like why they chose 10 to 15 years as like the follow-up time.
I think that this study was piggybacked on something that was already started, and so I'm not sure that they had a lot of choice in the time period. The other major thing that I wanted to point out as a limitation is that no baseline data was taken. No BMIs or hemoglobin A1Cs were taken at the beginning of the study. I think because they didn't realize they wanted to do this study when it was initiated. So we don't know anything about prevalence versus new onset.
Was it when they started this study? It looks like they interviewed people in 1998. Is that right?
94 to 98.
Mm-hmm.
But they didn't check the BMI
Until.
Well,
I didn't realize.
they tend to. Oh, okay. Okay. Yeah, I was confused about the data too. When I actually started.
So I think in general, it's a really interesting question for us to consider as far as like just in general, like what strategies would you implement in these neighborhoods? Because this is definitely like a kind of reverse of what it seems like we're kind of attempting to do, like putting people in neighborhoods versus, taking the people that are at risk out. It's kind of quite opposite and interesting.
Yeah, it doesn't. It talks like general neighborhood, but nothing like what about that neighborhood.
That too.
Just the property, but no demographics on like supermarkets and health clinics and stuff like that.
Be interesting to see what was left over if they took them all out of a certain neighborhood or certain area. What was the results of the people that actually stayed behind, of those people, if they were unaffected. If they had worse health, better health as a result. If you have a few that are better, but then the people remaining are actually overall worse, then
Well, that's what, when you look at the poverty, changes in poverty of the different neighborhoods, like, they all improved, but
kind of evened out over time.
but yeah, so the low poverty areas improved, but much less, a smaller rate.
I'm not sure if you can apply those numbers to census tracts in general, because we don't know exactly where these people were living. Does that make sense? Like, the data is in regards to a particular person, not to an area. Does that make sense?
Because it
What
can
am I-
be-
Low poverty.
Yeah, like, I don't think entire groups, like entire neighborhoods were actually moving up or down. I think that people were just moving around in between the poverty levels, and that's
And
the
they were
evening
big
out that you see.
cities.
Mhm.
They're really big cities. I don't think they're affected
Yeah.
I'm
too much of
surprised they
what
didn't put
happened.
the dose dependent chart in the actual paper here, because I feel like that answers the question that they were looking for more so than some of the other two things. Because what they're looking at is,
Supports it.
does moving to the being in that area affect their BMI and A1C, and I feel like that's the chart that would kind of answer that question.
Very possible. All right.
Is there another study like very similar to this that's come out?
I don't know.
Say that there's
Has someone
many
written about
studies
this, or
that-
was this presented at a conference? I feel like I swear
You feel like
I've
you've
read
heard
this
about
or
it?
seen this before.
Well, I know that there's a lot of studies associated with this particular data set, but I didn't look at any of them more specifically. So
Anyone else? We didn't watch a video or something. We haven't talked about this.
You're crazy.
It's hard when you've
I have
read
not read
so
this.
much.
My brain is so long.
I saw cameras together.
Yeah.
I know people have to get to clinic, but do y'all want to introduce yourselves real quick? I assume you're
Sure.
the students.
Yeah.
Okay.
I'm Joy. I'm from Ben Gurion University in Israel.
I'm from Utah and Carolinas.
Nice.
Welcome. Welcome to
I'm
Metro.
excited to have you.
Do y'all know what you're doing this week? Like, if you've been assigned to anything?